who's a consultant orthodontist at Glasgow Dental Hospital. He's been previous chair of the exam and is with me currently on the Specialist Advisory Board. And we also have Colin Melrose, my esteemed colleague, who's an honorary consultant at Liverpool and continues teaching there and had a long and fantastic career at Chester Hospital. He's also a member of the SAB. Between us, we think we've racked up probably about 60, 65 years worth of examining, and certainly 80 years plus in terms of clinical work. So we're hoping we'll be able to answer your questions on the exam this evening. We've had quite a few questions coming through the college early on. So while I will accept some questions as we go along, we've got a packed programme this evening, so it's highly unlikely we'll get through additional questions. I pre-primed our two esteemed colleagues to answer some of those questions, and I'll finish off at the end. So firstly, I'd like to introduce Toby Gilgrass. He's going to give you a quick overview of the process of the exam and some of the marking systems to give you a better idea of what to expect next week and in the future for our candidates. Take it away, Toby. Thank you very much.
Thanks, John. What I'm going to do is I'm going to try and share my screen with you guys. I have to say I'm delighted to be here, having just got off the motorway from sunny Glasgow. So let me go back to the beginning and we'll have a look and see where we are. Okay. So I was the chair of the exam up to about 3 years ago, and we've had some questions, I suppose, about not only the format of the exam, but as many of you will know, things are changing as far as the exam. And what I'm trying to do tonight really is to run through the process of the exam for those that are sitting next week, and I look forward to seeing you there. And also perhaps at the end, I'll just perhaps touch on what might be changing. Some of the stuff that is changing hasn't gone through ratification yet, so I won't be able to give you exact details, but I'll give you a pretty good idea how we see things are going to move forwards. So what am I planning to do? I'm going to talk a bit about the structure, and I'm also going to talk a little bit about what's changing, but we'll try and focus on the structure for you guys tonight. And also, I'm going to give you maybe a few sort of tips and hints about how we look at things during the exam and what sort of things you might want to concentrate on. So let's just go back to the beginning and talk about what the exam is there for. And I suppose in simple terms, we're there to look at your factual knowledge, and we want to see how you can apply that. And that is a bit about the written, I guess. We're going to look at your clinical skills, and we're also going to look at your communication skills, because that's obviously a huge amount about, or part of your job, isn't it? You're often talking to patients and parents. If you ask me my personal opinion of what it is we're doing, I guess I want to know what your knowledge base is. I want to know how you think, not necessarily how your supervisors think. I want to know whether you understand what sort of things you've been doing during your training. And I want you to probably justify what you do, because we all do different things, don't we? Even if you ask myself and John and Colin about certain ways of doing things, I suspect we'll all come up with different answers. And I guess most importantly, from a GDC point of view, are you safe? So, for those coming next week, what have you got in store? Well, I guess a lot of you will have already done a written paper. You can sit it, and I think it's been run on Monday. There will be a clinical component to the exam, and there'll also be a communication component to the exam. For those, there was questions out there that asked us how many goes you get at doing this. From a written point of view, you get 6 goes at doing the written exam. As far as the clinical and the communication, you get 4 goes, and that's combined. You can't pass one without the other at the moment, although that may change in the future. So let's focus on the written bit. Many of you will have already sat this, but essentially it's 180 questions. It used to be 1 3-hour paper, which was a bit of a killer. And we got lots of feedback saying that everyone found that really difficult. So what we've done now is give you a little bit more time, because it's not really a speed race, is it? Knowledge, it's about whether you can understand the question. So we've reduced it, well, we've increased the time to 2 lots of 2-hour papers, 90 questions in each, and you will get 30 minutes between each of the papers. So that comes to 180 questions. We've got some questions about what's in it. Of course you have. All I would say to you is everything that's in that curriculum will be tested in the written paper. We've got lots and lots of questions, and we make sure we check the blueprint every time we produce a paper to make sure we cover all the areas. For my colleagues out with the UK, what I would also advise you to do is to look at the advice sheet from the BOS and guidelines from the Royal College. We do cover things like medical emergencies, and everyone's favorite is materials, and we will cover materials to a certain extent during the exam, although I would say to you it tends to be more clinically related, how you might use a material rather than the basic constituents. I suppose the most challenging bit, I think, for the exam is the clinical aspect. At the moment, you will get 4 unseen cases where there's little booklets where there's some clinical information, photographs, x-rays, cephalometric measurements in there. You get 15 minutes to look at them, and then you'll get 15 minutes of a viva. And you will get different groups of examiners. People were asking how many different examiners will you get during the exam. We deliberately now make sure you see a different examiner for each of the cases. You will also present your own treated cases. You'll see I've got an asterisk by that, and that's what's changing come October this year. But at the moment, for those obviously in this diet and the September diet, you will be doing presented cases that you will have put together, and we will have looked at those prior to you coming into the exam, and that's the sort of questions we will ask related to them. You will know that I think last year we changed the marking system. What used to happen historically was you would have a viva, and we would have to choose a mark between 1 and 4. 3 is obviously the pass for the competent candidate. And what we've done since last year is we have increased the range of marks, in that you can now get a mark between 1 and 5. I think that's quite a positive thing. If you think about it merely from getting through the exam point of view, it allows us to much more easily award the excellent candidate. So historically, your top mark would be a 4, but now we can give you a 5. And that can make quite a big difference, I think, as you go through the exam, because for candidates that run along the 3s all the time, there is no chance of compensating very easily unless you get a 4. And I always felt it was a bit of a difficult decision for examiners to whether you were a 3 or you were a 4. And there was no way of really rewarding someone who was excellent. So now we have this 5th mark. Yeah, sorry, John.
Can I interject that? One of the questions was about compensation between, because the exams evolved over time and there used to be a compensation between different parts. You mentioned compensation there. And obviously within each section of the exam,
you can compensate.
For the cases, you can compensate if you had a particularly not so good diagnostic case, but then you did really well on the next, that can compensate within that group.
Yes, but not between the different communication. No,
so each individual part of the exam has to be passed in its own right.
Absolutely.
But within those sections, you can compensate.
Sure. Yeah.
That marking scheme makes it fairer.
Yeah, I think so. And if you look at what we do from a domain point of view, the beauty of using the domain system is the fact you're going to get a mark for your assessment, you're going to mark for your radiographs, you're going to get a mark for your plan, mark for anchorage, mark for mechanics. So it's much easier, I think, from an examiner's point of view to not have to worry about what's more important, a good radiograph or being knowing what your anchorage is. And that's what I think has improved things as far as marking is concerned, John. You'll also see the dark blue at the bottom is that we've got 3 marks, I think, essentially talking about your ability to treat a case, as opposed to the 2 marks you have for your assessment. There was always a slight concern that perhaps if you had equal amounts of marks, you'd be brilliant on assessment and have absolutely no idea clinically what to do. Whereas now you have to know what to do to get through that part of the exam. People have asked a wee bit about how we mark you. That we use something called a clinical rubric, and the rubric is quite a complicated piece of paper that essentially gives a description of the type of the score. So if you got a 2, you'd have a particular description. If you were going to get a 3, you'd have a particular description about the candidate's performance. What I've done for this slide is really just highlight some of the words off that rubric, because obviously there's a score for 1, 2, 3, 4, and 5. I've got the score for a 2, which is a failing candidate. I've got the borderline pass, which is a 3, and I've also got the score for a 5, which is obviously the top mark. Even if we just look at assessment, score of a 2 is for somebody who's very unstructured. Score 3, which is the passing candidate, gets most features. But if you look at score 5, what we're looking for is structured, all the features, and some references to match. And that gives you a bit of an idea as you go through looking down that list, how we would look at a candidate. People often ask, do you need references to pass the MAuth? And the answer is no, you don't. But if you want to get yourself a good score, you're going to have to come up with something, some evidence base behind how you get anything done mechanic wise, or how you've looked at radiographs, or how you've chosen your anchorage management. Because examiners are very experienced and are very good at sort of walking you through each individual assessment process here. So assessment, radiographs, planning, anchorage mechanics, and getting you to that score of 5 if you're doing well.
Toby, this might be another good place to address one of the questions. Somebody have asked, how is the exam standardized in terms of its subjectivity? Different examiners from different backgrounds with different ideologies. Certainly, when I sat MAuth 20 odd years ago, we sat down and people would bring their own cases along. They would talk to you about your MSc rather than going through. I think it's really important candidates recognise how structured the exam is now.
Yeah. I mean, it's interesting, isn't it, John? You and I both would look, and you'd look at whoever you saw as you came across the desk and think, oh my goodness, not them. And they'd bring out their old favourite, and you'd have lots of questions on that. We don't, obviously, I mean, I don't know either college do it, but we would be very careful about making sure that we cover the entire blueprint of the exam. The rubrics are essential, and they are sitting in front of the examiners, which means that they're marking, before they give you a mark, they will look at the rubric and match which aspect of the rubric closely matches what you've done. The exam also evaluates the scores of every examiner. So, for example, if you had a candidate who was doing very well and everyone was giving them fantastic marks and one examiner gave them a 1, that would flag up. And we're very careful about doing a lot of examiner training before they get to the exam, but also very careful about how we assess performance of examiners throughout the whole process. So I think candidates can be reasonably reassured that people's faces often change, but the marking's fairly consistent.
I think as regards the cases as well, when you're given a short case, the marking is absolutely clear. This isn't about what the examiner thinks should be the treatment.
Yes.
Before we go into that section of the exam, we have a crib sheet that has virtually every potential plan that is possible for that patient. What we're looking for is you telling us why you think that plan is reasonable for them.
I mean, John, we genuinely don't mind, do we? It doesn't matter what you come up with, but I expect you to be able to explain why you've done what you've done.
It's the justification that's the important bit. So don't see somebody sitting in front of you. You think, oh, that person really likes RME. I'm going to use RME in this case. Or I saw that person never takes teeth out. I'm not going to take teeth out in this case because they might not like that. Yeah. That's not how the exams run.
Every case has been assessed, and there's a crib sheet that tells us what is acceptable and what isn't before you get there. So I know I've seen that myself, John, where someone's come in and I've been sitting with somebody who's, let's say, does everything, a lot of non-extraction. They look at them and think, oh my goodness, throw their sheet out the window. I better do this non-extraction. And I say that actually at the end of this chat, just do what you do. Don't try and do, for the first time ever, RME and protraction headgear, because it can only go horribly wrong, really. Is that okay, John?
Lovely, answers that nicely and hopefully reassures our candidate.
Thanks, bud. Okay, so we've talked about clinical communication. Again, we have domains. So we had 5 marks again for each of the domains in communication. And the domains we use, there are 6 of them. We use humanism, professionalism. Communication, we've actually split up into 2 different groups, explaining or imparting knowledge, and listening, which is fascinating to watch as an examiner. Organization, and the last one at the bottom in a different color there is inspiring confidence, and that's a mark from the actors that are there doing the exam. If we look at the rubric for those, I'm just going to run down the score for 2. So for somebody that's failing, they tend to be quite poor at engaging with the actor, in that they won't come in and say, hi, how are you? There's no kind of communication to start off with. Their manner tends to be a bit brusque. They use lots of jargon when they're explaining to patients about how a treatment modality might work. And they certainly don't check understanding. A lot of candidates will come and say, well, I'm from overseas, it's not my first language. That doesn't stop you asking the actor, does that make sense? Did you understand what I've just said? Or, look, I'm sorry, this is not my first language. This is what I'm going to try and explain. Please stop me if there's a problem or you don't understand. So that's not an excuse for not getting through this. I think that if you use normal sort of language that we would use in a clinic, you will get through this without too much bother. Dominates. It's interesting. I had the pleasure of 4 10-year-olds round for tea last night, and what happens at those is that nobody listens to anyone. They just shout really loudly, and there is no point where, when they're trying to give an explanation, they stop to allow the other one to give an answer to it. Communication is not about just telling them what you need to know. It's about listening to the actors as well, and the actors will be organized enough to ask you some questions, and when they ask a question, it's really important you give time to answer that and make sure, seek clarification that they've understood what you've said.
Can I also, again, just reassure candidates? I know it's an artificial situation, but most of the way that the communication tests are set now is that they're set as though you're talking to an adult a lot of the time. So
yes, almost certainly.
You're not trying to imagine a 30-year-old guy as a 5-year-old girl, but also our actors are incredibly well trained. They've been coming to this exam for many years. Again, we have a session where we go through the questions and clarify all the details in the scenarios with them. So they should be reassured that they're in good hands with the actors. The
actors are fantastic, John, and we've watched them over the years, from the days when we used to do the acting ourselves to now, and the actors are amazing. And what we do before we start is we'll have a scenario and we will sit with them for half an hour and just talk through what sort of scenario, what does that mean? They've also got stuff in there about how they feel about things. So they might be an anxious patient, or they might be a slightly aggressive patient, or they may be a not bothered patient, or they might be a parent that's arrived and they were 20 minutes late arriving because the car broke down and stressed when they get there. And what the actors can do is absolutely amazing. So I think that we spend a lot of time making sure that they're well prepped before the candidates arrive. And also, I think as well, John, we've talked about this before in the exam, that a lot of it is about communication. It's not really necessarily about knowledge. It's about interacting with the actor, isn't it? It's about them listening, you listening, and just having a bit of rapport going.
Yeah, and again, from a candidate's perspective, we're standing in the background. We're not interacting with you at all. You will carry on, and you treat it like you would do on every day on clinic.
Yeah, what tends to happen is most people sail through without too much bother, because if you just slip into that, what do I do on clinic every day, you will be absolutely fine. We've been asked a bit about what sort of things might you get to do. Sometimes there are things like delivering bad news, wrong tooth has been taken out, your roots are shortened, you've got some marks on your teeth, and you're explaining to a parent about that. There might be explaining a plan. So you've decided to fit RME and protraction headgear, and you're explaining to a dad why you might be doing that, what sort of problems that might have, what are the risks and the benefits of that sort of treatment. Again, modalities, and I suppose reassuring parents, don't want teeth out. Can we do it without taking teeth out? And you've looked and that desperately needs extractions rather than non-extraction. So some of the scenarios are about reassuring adults about certain treatment options. Okay. Before I finish, I'm just going to talk a little bit about what's changing. And I said at the start, a lot of this information hasn't completely been ratified yet. So I can tell you what's definitely going to happen and what I suspect the new scenarios will be like. But I'm going to put a wee sort of asterisk against that and say, look, as soon as we know, there'll be something on the website to explain exactly what's coming. So at the moment, I've explained what will be happening with the exam from October 22, the end of October 22. So this diet and the September diet will be exactly the same. But from then onwards, we will lose the presented cases. And I realize that this has caused some angst. All I would say is that I think it's been driven by people much higher up the food chain than me, and also by the educational department within the college. I'm going to be honest with you and say, I'd be interested to know what you guys think, but I think there are a lot of positives to be taken from it. I know you'd say I would say that, but I think, remember the slide at the start where I talked about, I want to look at what you know, what mechanics you use, your ideas on this. I think removing the case books, which were planned not necessarily by you, and have been prepped by you and your consultant, is quite a positive thing, because we can actually broaden what we will look at from the blueprint. And I wonder whether you'll probably get the same sort of questions you would have done if you had a casebook there, based on what I think we will probably start using.
I think one of the things there, Toby, is about the standardization as well. Particularly as the MAuth got earlier and earlier in the year, we're seeing candidates bring either unfinished cases or more simple, straightforward cases that are finished.
Yeah.
And it's very difficult to fail those candidates. It's very difficult to give them good marks. And one candidate may have some really rock hard, amazing cases, and the other straightforward, but they'll both pass and both get similar marks at the end of the day.
I suppose it also takes out
that section.
Yeah, it also takes out that whole horror of thinking your mate's got some great cases and you don't. It takes out the uncertainty, doesn't it? But I think, as you say, John, it allows us to check or test a lot more areas of the curriculum than we would if someone brought 3 Class 2 Division 1s, I guess. So people will ask, okay, so what are you going to do? This is my guesstimate of what I suspect we will do. I think the cases will obviously be unseen, and you will get 15 minutes probably beforehand. So rather like the usual unseen, the information you will get will be more abbreviated. But I think more importantly, I think we'll end up giving you a plan and some mid-treatment photographs, I think, is what's going to happen. I suppose for the guys out there sitting the exam and go, why are we doing this? It's a bit like a transfer case, isn't it? I think what we're actually doing is we're getting you to think on your feet. And I do wonder going forwards, John, that we will end up probably asking the same questions we would anyway. We're using the same rubric. I think the same questions we would use, but on a broader range of topics. So I think going forwards, that's how I think it will happen. I can't confirm that tonight, but I suspect that's the sort of the direction of travel.
I mean, from my perspective, if you think about the sort of the highest qualification to become a consultant in this country, when I sat that exam, I took 3 cases along. And within 3 to 5 years after I became a consultant, the cases were removed altogether without consternation, with clinical scenarios very similar to this. so that everybody was judged on the same material coming through.
Yeah, I mean, it really gives consistency, John, isn't it? It's consistency. It's not about your unit, it's about you, and you'll get the same cases. So I think I do think it's positive.
I think personally, I've been training for 20 years, I'll still want my trainees to go through their cases and reflect upon them. It's an important part of learning, but that's part and parcel of being a consultant trainer, an educational supervisor, and training program directors. I'm sure will build that into their programs. But despite the consternation, I think it will be positive. It hasn't been led by the SAB, but by the educationalists. But they've made it very clear that that's a way forward for the exam. The MAuth is currently the only exam at the college where people bring cases along. It's an outlier.
Yeah, and that's in medicine and dentistry. It's medicine and dentistry, isn't it?
Yeah.
Yeah.
Colin, your thoughts?
I think the changes have been made, and I think it's important that the candidates understand the motivation for those changes. And they've been made to make the exam better quality and fairer for the candidates. No matter what happens with the changes, Edinburgh will remain what it's always been, a fair and high quality exam. And candidates will continue to have a positive experience of sitting in the exam in Edinburgh. And it's not called the Friendly College by accident. There have been changes in the past, and there's been quite a lot of anxiety when, for example, the essay section was removed and the unregulated fibres, and there was concern about the quality of the exam being diminished. In the end, things continued in the same high quality vein, because what was removed was replaced by a well thought out assessment that was fit for purpose. And I'm sure the same will happen now.
Thanks, guys. Thanks for that, Toby. That's a great summary of the exam, and I think very useful for the candidates. I'm sure there'll be a few butterflies in the tummies around the country, but I promise you we're here to look after you and get you through the exam where we can. So, thank you very much for that, Toby. There are a few just minor points about the exam that we had questions for.
Sure.
We've answered the one about compensation.
Yep.
Somebody was asking, with their cases over the next 2 diets, are they allowed to bring printouts in? And are they allowed to bring annotated printouts? I think the problem with bringing anything annotated is, as an examiner, we don't know how much information you've put on there. Your cases will be in front of the examiners anyway, so you shouldn't need them with you. So you can bring a plain printout, but I wouldn't necessarily recommend it. Those will already be there with the examiners, and they will take you through the aspects of your cases that are needed. Somebody's asked a very simple question. Do we get given paper in the exam? Yes, don't worry.
Oh, yes.
We provided with some
and pencils, everything.
There was also some concern about the timing. One particular person emailed asking, I've been timing myself for 7 minutes, but I need my watch handy. Am I allowed a smartwatch? Well, clearly you're not allowed a smartwatch in this day and age, because it's like strapping a supercomputer to your arm, and all sorts of information can come through. So you will be asked to obviously not have your phone or a smartwatch.
Examiners get theirs taken off them as well, John, don't they?
Old-fashioned watches that just have hands on them. And
men of a certain age, John, men of a certain age.
But also, partway through, you will have a half-time bell. So we will always be told. That's useful both for the candidates and the examiners, because both the examining and the review of the cases is ongoing at the same time. So you'll be given a half-time bell to let you know that you've got half your time left, and that's usually very helpful. But if you haven't got one, buy yourself a cheap analog watch. I think that would be sensible. Now, what I'd like to do now is pass on to Colin Melrose. I've passed on a couple of the questions on a clinical sort of leaning for him. And as he's put together a few slides just to illustrate those, I'll let Colin ask the questions and answer them, and then I'll finish off with a few questions. So I'll pass over to you, Colin. Thank you very much.
Okay, thank you very much, John. Toby, could I ask you to stop sharing so I can assume control? Good. Okay, so good evening, everyone. I'd like to just run through a few questions that have been submitted. And the first question I'd like to deal with is, in class 3 cases, do you use MBT prescription in the upper arch or Andrews prescription? Some books advocate Andrews as it's has less palatal root torque and is less likely to reduce the overbite. So that was the question. So to answer that, I'm going to just show a class 3 case that's going to be treated by camouflage, but it's got a tenuous overbite. And the simple answer to the question is, my advice would be to use the MBT prescription for both arches. The 17 degrees incisor root torque in the upper arch and the -6 in the lower arch will be helpful. And if you're worried about the overbite, there are several techniques that you can use to help you deepen the bite during treatment. So this case is a 15-year-old young lady. She's got a 2-4 contact on the left-hand side with a blocked out canine tooth. And in the lower arch, she's got a congenitally absent lower left 5. So we're going to treat the case on an extraction basis. Looking at the Kaplan-Meier, she's only got a very mild class 3. The A and B difference is 1 degree. And in terms of the incisor inclinations, the uppers are at 116, the lowers are at 90, with a 30-degree angle. So it's a class 3 camouflage case. We're going to procline the upper incisors modestly and retrocline the lower incisors. So we've taken teeth out, 2 upper 4s and the lower right 4. Remember, the lower left 5 was congenitally absent. We're going to level the case. I'm just going through this very quickly to this stage. And at this stage, I'll really want to discuss the vertical management. So we've got some space remaining in the lower right quadrant, and I'm going to use that space to fulfill 3 goals. I want to correct the lower center line, I want to deepen the bite, and I want to retract the lower incisors from class 3 edge to edge into secure class 1. Now, in terms of vertical control, the very fact that we treated this case on an extraction basis will help us deepen the bite, because as we close the lower space, it will retract the lower incisors and the bite will tend to deepen. Other things we can do are put an increased curve of spay in the lower arch wire to deepen the bite. The sharp-eyed amongst you will also notice the incisor brackets have been bonded slightly gingerly, and all these things will add to one another and help the vertical control. So if we watch the case as that lower space closes, we can see an improvement in the center line, and we can see a deepening of the bite at the same time as the case is camouflaged. And there we are towards the end of treatment. We're in a secure class 1 and we've got a positive overbite. So in terms of prescription and overbite control for class 3s, I'd recommend MBT prescription, and I wouldn't worry about overbite control as part of the prescription. I build the overbite control into the mechanics as I've just described. And that ended up a nice secure class 1 in the end. Okay, the next question is, if you place a bracket more incisal, do you get more or less palatal root torque? And the same question if you place the bracket from the gingival. So let's have a little look at this diagram. We're all used to placing our brackets in the middle of the clinical crown in zone 2. Let's imagine this is an upper incisor and we've got an MBT prescription bracket on 17 degrees. And if we put it in the classical place of the tooth, we'll get 17 degrees of positive root torque. If you displace the bracket to a more gingival position into zone 1, you'll get less torque. And if you displace the bracket more incisally into zone 3, you will increase the torque expression. So I hope that explains how moving the bracket vertically on the tooth affects the torque.
Again, Colin, that's a factor really of the curvature changing the inclination of the bracket base, isn't it? And
yes.
The slot inclination will change. If you have a very flat tooth, you'll get very little change or maybe increase the torque moving up. But if you're looking at teeth such as if you have a significant crown root angulation in a class 2 division 2 and you want to help your deep overbite by bonding that a little bit more incisally, actually it will help improve the torque to that tooth as well.
Yeah. Okay, so quite a few questions about headgear. So I just want to spend a little bit of time about what questions would I ask about headgear, or what questions do I hear other examiners asking? Well, they fall into 5 broad categories. First of all, the candidate should know the indications for use of a headgear, the mechanical principles of headgear. They should be able to describe the clinical procedure of fitting and adjusting headgear. They should be able to describe how they monitor progress and assess compliance with headgear. And they should be able to discuss headgear safety in terms of the BOS guidelines and specific safety features of the various components of headgear. So let's have a little look at some of those in a little bit more detail. First of all, mechanical principles. We'd expect a candidate to understand what's meant by centers of resistance of both the maxilla and the upper molars. We'd like them to be able to discuss direction of force vectors for headgear, appropriate magnitude of forces, and appropriate duration of forces. We'd expect the candidate to understand and be able to describe the center of resistance as a point at which a resistant to movement is concentrated, or the point that promotes translation. And for upper sixes, this is usually the area of trifurcation of the root. For the whole maxillary arch, it lies between the premolar roots, often referred to as the M point or Poulton's point. Now, a headgear force passing through the center of resistance will result in pure translation of the molar. If the force doesn't pass exactly through the center of resistance, you'll get a mixture of translation of the tooth and rotation or tipping. Now, there was another question sent to us about the level of the outer arms of the face bow when using headgear. In most cases, the outer bow should be at the trifurcation point of the upper sixes, opposite the center of resistance, in order to get pure translation. The position of the outer arms of the headgear in the AP and vertical planes will affect the position of the resultant force vector relative to the center of resistance of the upper sixes. And if the force vector is above the center of resistance, it will rotate the roots of the six distally. If it's below the center of resistance, it will rotate the crown of the six distally. So looking at that diagrammatically, ignore the red arrows, they don't add anything. If we look at scenario A, and the distal force, the headgear force, which is above the center of resistance, that will tip the crown backwards and the roots forward, as well as a degree of translation. In scenario B, where the vector of force is applied above the center of resistance, then the roots will tip distally and the crown will tip mesially. And if the force vector is adjusted by means of the outer bow to pass through the center of resistance of the trifurcation of the roots, then a pure distalizing force with no tipping or rotation will be observed. Now, candidates are often very worried about the presence of second molars when they're trying to do distal movement with headgear. Unerupted sevens rarely cause resistance distal movement. If you've got fully erupted sevens, they'll create a resistance which will affect the magnitude of the force needed for distal movement. So you'll need to increase your force. And the presence of erupted sevens will also cause more of a rotational movement and cause distal crown tipping of the upper sixes during retraction. So looking at force direction, headgear is usually described by its relationship to the occlusal plane. If it's below the occlusal plane, it's low pull or cervical pull. In line with the occlusal plane, it's medium pull or straight pull. And above the occlusal plane, it's described as high pull. So each direction of pull has a vertical component which may extrude or intrude a tooth or arch while producing the desired movement in the AP plane. And finally, the lateral force components can be introduced to the headgear bow by expansion or contraction to alter the transverse dimension of the upper arch. Okay, well, that finishes the headgear questions that were submitted. The last section I'd like to deal with is quite an interesting question. When placing TADs for molar intrusion, how far from the gingival margin in millimeters do you place them to avoid the nerves and the blood vessels? So let's have a look at this case. This is a case I treated, an anterior open bite that we're going to manage by intrusion of the molars. And just by modest intrusion of the molars can have quite a significant effect anteriorly to the anterior open bite. These are the mechanics that we use to produce that intrusion. And really, my concerns about sighting the TAD are not where the blood vessel and nerve are. Usually what happens with the artery is it's got quite a thick collagenous coat to it. And when you're pushing your TAD through the mucosa, if you near it, it tends to roll around the neurovascular bundle rather than transecting it. And the greater palatine artery is quite a minor artery. And if you do get a bleed from it, it's easily controlled with a short pressure with gauze. It's unlikely to be a significant problem. So I really choose the site of placement of my TAD for intrusion, not based on the blood vessel, but really based on avoiding contact with the roots of the molars. The other thing is that you've got to plan for the amount of intrusion that you're going to get. So it's a mistake to put your TAD down too far towards the gingival margins of the molars, because as you intrude the molar, it's going to begin to interfere with your TAD. The other factor is that you need the most convenient way of loading the TAD is with power chain, and you need a decent length of power chain to get a decent intrusive force. You don't want to be trying to fiddle around, trying to stretch a power chain over a distance of 2 millimeters. You're just not going to get a decent force. You need a good centimeter or more. And the final thing is that you want to put the TAD in the vertical aspect of the alveolar bone rather than the horizontal palatal shelf here, because if the TAD's too horizontal, the power chain will just slip off when you hook it on. So having the TAD angled at 45 degrees on the vertical shelf of the alveolus helps retain the power chain round the attachment point. So palatal vaults vary from shallow to very high palates. So the question was how many millimeters? Well, it varies between the patients, but really the sighting of the TAD for intrusion is based on getting clearance between the roots and getting a decent force vector to stretch your power chain. And the last feature is you want to angulate your TAD so the power chain will be self-retentive around the ball head.
Colin, someone's just asked at what stage do you remove your TPA? I mean, I tend to get my occlusion pretty much settled before I finally remove the TPA, and I keep the traction fairly passive for a few visits. I don't just get the AOB down and then immediately take off the transpalatal arch.
No, I retain it for a while, and then during finishing, the TPA won't allow your buccal segments to settle, and it will fix your transverse plane. So if there's any final arch coordination, you can't do that with the transpalatal arch on. But I agree, it's a mistake to take it off immediately the first visit after you've got a positive overbite. You want a degree of overcorrection, and you want to retain it for a while, but do remove it towards the end of treatment.
That's great, thank you.
I think that just wraps up my questions, John. So thank you very much for giving me an opportunity to speak tonight.
Lovely. Now, as you've sort of just shown a high angle case, and we've talked a bit about headgear, one of the questions is coming in, and this suddenly crops up, and it is a worry for candidates, is that in a high angle class 2 case, whether that's normally class 2 division 1, maybe with reduced overbite, is it okay to discuss using high pull headgear attached to a set of twin blocks? Now, I'll talk about my own personal experience. I have tried that technique, and I personally these days don't use twin blocks for high angle cases. I find that it makes a long face even longer, and I do struggle with my overbite. And although I have got away with it in the past for patients, I tend to manage them differently now. I'd much more likely go for an extraction-based plan. I'll much more likely use a TAD TPA to support my molar position and prevent any extrusion. What about you and Toby? Do you want to answer first, Colin? What's your thoughts on using high pull headgear? It's an option, and it's an option that we would investigate with you, and you can discuss the advantages and disadvantages. You certainly wouldn't fail for saying it. Personally, these days, it's not a technique that I would use.
Thanks, John. I think if you're introducing two-phase treatment, you're going to have a long treatment plan. And there's got to be a benefit from the twin block phase. Now, in a low or average angle case, the literature supports that you're going to get a tangible benefit from your twin block phase. That 20 to 30% of skeletal effect that happens on average in twin block cases will be very useful because it will be directed in a downwards and forwards direction. In a high angle case, if you get that growth, it's going to be vertical. And as you say, it's going to lengthen the case. You're considerably lengthening the treatment plan by another 6 to 9 months. And you're going to have very little to show for it. I'm happy to discuss that with a candidate, and they'll, if they justify it, they will get a reasonable mark. But if they want the highest mark, I expect their treatment plan to be, I think there needs to be an element of time management and efficiency in the treatment plan. And a candidate, I think, would be more impressive if they identified the high angle case, identify that they were likely to have a poor growth response in a high angle case, and organise their mechanics more efficiently with anchorage from either high pull headgear or from a TAD TPA.
Thanks, Colin. What's your thoughts, Toby?
I have enough battles getting him to wear the headgear or twin block than putting both together, to be honest. Yeah, candidate wise, I have no issue with them offering it. You know, if you look back to the rubrics, there's a bit in there about, okay, I might say, look, that's really interesting. How do you think that's going to go? Do you think that's going to be easy, straightforward? And we talk through evidence behind it. But remember, there's always the other option. And again, if you've got that other option there, I'm always going to ask you, what's your preferred option? But be able to talk through both would give them a great mark anyway. Yeah, my success rate with high angle twin blocks isn't particularly sparkling. You don't get many in cleft cases, so it's a bit easier for me than it ever used to be. But certainly historically, when I was supervising the trainees, yeah, I have to say you become a bit more pragmatic as you get older, don't you?
It's an experience thing. When you've done a few cases and found out how difficult it is, you revert to probably a more pragmatic treatment plan. And I think part of the problem with managing a high angle case like that is that you're probably going to have to go into extractions if there's any form of crowding to try and re-deepen your bite. And then the only way you can then control your vertical in the second phase of treatment is to reward the patient from their twin block and headgear by saying, right, now we're going to fit the headgear to your teeth as well. And you've really got to carry on that high pull headgear probably throughout the whole length of treatment to manage the vertical. So personally, it's not something I would definitely plan myself. But as long as a candidate had a good appreciation of the difficulties of going down that plan, if they went blindly down and said, well, there's no problem with it at all, that would worry me. Right. That's time for me, I think. I've got a couple of questions to answer before we finish off this evening. So let me just start by sharing my screen. I'll see if I can find my PowerPoint here and share that. And we will bring that up onto there. So let's just go back. A couple of questions, really. The first question, and there's something often comes up about curves of Spey. A question I often ask candidates when they talk about placing a curve of Spey in a rectangular arch wire is, what is the effect of placing that curve of Spey? And it often draws a few blank faces, and that's because there's not enough appreciation of the way it changes the torque within your arch wire, not just anteriorly, but posteriorly, but also the effects potentially on, particularly in the lower arch, flaring lower incisors forward. So I've only had a short time to just put some diagrams on. So we've got an accentuated curve of Spey here in the upper arch. And if that's a rectangular 1925 stainless steel, as you get into your anterior segment, that's going to tip your arch wire and cause additional palatal root torque. But you've got to remember that that torque is now across the whole of your arch wire. So you'll get a little bit of flaring of your incisors forwards. You'll get some palatal root torque, hopefully some reduction in the overbite, but also you will get the same torque in your buccal segments, usually to slightly lesser degree, but that can cause your palatal cusps to drop. And if you put a really deep curve in, it can create quite a lot of friction trying to get your arch wire in. So it might be that you want to remove the torque by using a pair of torquing pliers and simply just twisting the torque out of the back, or you round out your arch wire a little bit at the back. But if you've already got a case where you've got dropped palatal cusps or you've struggled to expand an upper arch, you just need to know the potential effects in that upper arch of placing the torque. And the same really goes for the lower arch. If you're struggling trying to think of that, think this is a velodrome track or any sort of major racetrack like a NASCAR or velodrome, and you can see that curvature goes around the whole of the arch. And that's the same for when you put a curve of Spey in an arch wire. So in the lower arch, you'll get increased labial crown torque, as well as intrusion, as well as proclination of your lower incisors when you place a reverse curve of Spey. Often it's more useful though, because you'll tend to put that in a deep bite case. Often in a deep bite class 2 case, the lower arch can be a little bit rolled in, and the torque in the buccal segments will actually cause more molar uprighting. So that's often helpful to you. So often I will tend to not take the torque out in my lower buccal segments, because particularly if I'm using class 2 elastics, that extra buccal crown torque and molar uprighting will counteract the effect. So just appreciate that if you're saying you're going to start putting curves into wires, what effect it has around the whole of the arch, and whether that's beneficial or detrimental in your case, and whether you should try and take some of the torque out if you don't think it's helpful to that particular case. The final question was on scissor bites, and that was, how do you correct scissor bites? Well, that's quite a big topic, but I thought I'd just list a few of the ways that I manage scissor bites fairly quickly, just so that you've got a ready reckoner if anything comes up in the exam. Firstly, with scissor bites, you've got a locked-in occlusion like we have up here. We've got the palatal cusp locked outside. That can cause issues with knocking brackets off, and it makes it very difficult to try and bring the lower arch out. So you nearly always have to unlock the bite in some way, shape or form. You need to try and narrow the upper arch and expand the lower arch. And for me, I tend to swap my arch wires around. So I will tend to just put a lower arch wire in my upper and an upper arch wire in my lower from that first visit. So from visit 1 with my lightest night, I'm already starting to make some changes to the arch coordination at a very early stage as I unlock the bite. Now, as our lower arch tends to be rolled in and trapped, particularly in deep bite class 2 cases, I want to express that buccal uprighting as quickly as possible. I use an MBT prescription. It has much more molar uprighting. That was to, again, resist the effect of class 2 elastics. So I want to get into a rectangular arch wire at the earliest possible opportunity. So I'll be getting into a rectangular NiTi early on in treatment, not going through stainless steel round wires. And it might be that the best way to manage this, if it's an extraction case like this one up here, just simply think about taking out the tooth that's in scissor bite, and suddenly that scissor bite's gone and you've got a much easier arch wire to coordinate for the long term. If it's an AP discrepancy, i.e. you've got a significant class 2 where there is underdevelopment of the lower arch, it might be that you use a fixed functional or a twin block. And it might be then in your twin block that you don't need an expansion screw. So don't always stick an expansion screw in your twin block. If you've got bilateral scissor bites, there's a good chance you don't need any arch expansion, and just changing the AP arch coordination will improve your scissor bite tendency. Cross elastics are great if your patient will wear them, and they are not the easiest things to fit for patients, and they can be quite awkward on the tongue. You can see this as an adult patient. You can see that the upper right 7 here, the palatal cusp of the upper right 7 is almost on the gingival margin of the lower right 7. And we've got a similar issue here with the upper 6 down on the lower 6. This was a private patient of mine I treated as an adult. She struggled to wear these so much during the day, but at night time was fairly happy. So I've got a button on the lingual of the lower arch, and we just run that cross elastic to try and upright the lower molars buccally and tuck the upper molars in, and that was nicely successful to resolve that along with the arch coordination. I'm just going to finish off with a case. This is Jenny. Jenny's quite a complicated adult case, and we'll have a closer look at her overbite in a minute that is absolutely horrendous, and that was one of her complaints. She's got bilateral scissor bites of the 4s and 5s, and the main problem was mandibular alveolar excess. You can see you can't see the lower incisors there at all. We have an incredibly deep curve of spay in the lower arch, and the whole of the lower arch is trapped inside the upper, causing the scissor bite tendency. In fact, you can see on the palate here where the upper arch sits all the way around the anterior segment. That's why there's the shape of the lower arch. It's almost omega shaped. Everything's tucked and rolled in. So we really need to upright and round out that lower arch as quickly as we can. If we look at her smile, she's got almost a gummy smile, but in reverse. It looked to me like she had no teeth there at all in the smile, and it just looked weird, and that's what she disliked. She had slightly reduced upper incisor show, but it was the look like I haven't got any teeth in the lower arch, which was her main bother. So in this case, I'm trying to improve her upper incisor show by extruding them, but I've also got to do a lot of intrusion of the lower and correct those scissor bites. I'm looking at bracket positions, so I'm bonding much more incisally, particularly in the lower arch. Down here, I bonded my molars a little bit more gingivally, and I've rotated the brackets to upright them. And I've got very early on into a rectangular NiTi. I used 2020 nickel titaniums for my uprighting. I've got a lower arch wire in the upper and an upper arch wire in the lower to get early arch coordination, and the bite's propped open at the back. You can see the arch wires uprighting quite nicely, and that rounds out quite effectively by getting early into that NiTi and tying in nice and firmly, so that we get a nice arch form. What you also see is that I use some pliers to put down sets rather than using auxiliary mechanics to correct deep bites. I just use my nickel titanium arch wire and put a permanent bend in that arch wire to overcompensate and take those lower incisors down. And that downset bend helps me level really deep curves of spay, even in adults. This is a plier that I tend to use. You can buy them in 0.5, 1 mil and 2 mil, and it puts a really nice sharp bend into a nickel titanium that will keep it there permanently. And that really helps level the arch out nicely. You can see the overbites come down well. I've now moved into stainless steel, again, an upper stainless steel in the lower. I've just changed the bracket position to improve the torque on this canine. And here she is at the end. a much happier patient with an improved in smile line at the top. And really importantly, you can now see that she's got teeth at the bottom and arches coordinated with the scissor bites corrected. So arches nicely rounded out, supported with bonded retainers. There we are at the end, scissor bites corrected. So I hope that helps a few candidates with some of the complexities of managing scissor bites. We've covered quite a lot of information this evening. I'm really grateful to my consultant colleagues, Toby Gilgrath, Colin Melrose, for joining us. I hope you found the webinar useful. I hope there are not too many butterflies. We look forward to welcoming you next week to the exam if you're sitting next week or later on this year or in the future. We do have another webinar later this year. I'll keep running them every 3 to 4 months or so. Our next one is with Professor Fraser McDonald, and we'll be talking a bit more about mechanics in orthodontics. So without further ado, I would like to say good night. Thank you for joining us and spending your time with the Royal College of Surgeons of Edinburgh. Thank you, Colin. Thank you, Toby. And I look forward to seeing you all again soon.
Good night.
Good night all.